Hello friends, welcome back. Today we'll talk about SIRS, which stands for Systemic Inflammatory Response Syndrome. We shall discuss the evolving definition of sepsis and septic shock and what are the definition by CMS and surviving sepsis campaign guideline. Some sepsis bundles, management of sepsis, fluid resuscitation, colloids versus crystalloids, and some screening tools like SOFA versus qSOFA, and some evidence-based studies and what are their recommendations. I'll start with the sepsis first. Well, what is sepsis? Well, in lay terms, I will say it's a question of life and death type of situation which affects millions of people all over the world. And if you look at septic shock, it has about a very high mortality rate, about 40 to 50%. And those who survive septic shock, generally they suffer from long-term sequelae. Once the patient actually enters the septic shock, most of the time it leads to multiple organ failure and death. Sepsis, in fact, is a very complex condition where both the inflammatory, I'll say pro-inflammatory, as well as the anti-inflammatory responses are working simultaneously. The extent and the duration of infection depends upon what type of bacteria or pathogen has invaded our body and patient's condition as well. Does the patient have any other comorbidities? A lot of factors are involved. When basically when a pathogen attacks our body tries to defend itself. It reacts in a certain way. It's a very complex mechanism. Sometimes the body cannot quickly figure out what is the pathogen, and what happens is that our defense system overreacts. And the result of this excessive overdrive response of our defense system, they say collateral damage to the normal tissue or the normal cells. So once these normal cells die as well, they go under necrosis instead of apoptosis. They say difference between normal cell death and this death due to infection. Generally, in a normal cell, we call apoptosis. It's a programmed cell death where the cell shrink and dies. Whereas in the inflammatory response, the cells swell up and release the contents. And inside the cell, if you look at, there's a lot of chemical reactions going, a lot of chemical, excuse me, inside. So what happens once the cell release those content outside, they also can cause a problem to the other normal tissue. For example, if you look at the cytokine release syndrome or the tumor lysis syndrome, the normal components of the cell gets released like potassium or phosphate or uric acid, so they can cause metabolic issues as well, especially during the early phase of the infection. The body releases a lot of neutrophils and other inflammatory cells. In fact, the early phase, I'll say, is a pro-inflammatory phase. Body is dumping a lot of neutrophils to fight the pathogen. Generally, neutrophils die they have very short lifespan, less than about 24 hours, But what happened during infection, the normal death of the neutrophil is also suppressed, so that instead of dying in 24 hours, they're gonna survive for longer time, So more neutrophil doesn't mean that you say good defense. Too many, I will say, defense pathogen accumulating around the cell to fight it off is instead of helping, it creates a problem. So that's the issue with the overactive excuse me, overactive like inflammatory response of the body. Generally we have the defense mediated through the T lymphocyte or the B lymphocyte or the CD4 or the CD8 cells. And these lymphocytes basically take a little time to respond, whereas the neutrophil are the first responder in a way. But excessive neutrophil count, I will say, um, I'll say like can increase the risk of thrombosis, especially very small thrombi or in the microvascular circulation. So those effects which are getting the blood supply, especially the microvessels, smaller blood vessels, clot formation, the the tissue can get the uh, impaired oxygenation because of the blockage, and a lot of complication, basically bleeding, DIC, so many issues actually come into play when it's like when the coagulation system gets involved actually. Now let's look at the evolving sepsis definition. Why there are so many actually, definition. If you look since 1992, the proper definition sepsis or severe sepsis or the septic shock has been under debate, and sepsis definition have been evolving over time. Uh, some terms like severe sepsis is not used anymore since 2016. Why, I'll say, why is so difficult to define sepsis? Well, the reason is a complex pathophysiology involved behind the sepsis, and because there can be multiple organ system involved simultaneously, and there's not one fixed system which is affected every time the sepsis occur. Any system can be affected, therefore it becomes very hard to reach a consensus to define the sepsis properly. They have been updating the definition from time to time. For example, there was sepsis 1 and then sepsis 2, and now we have sepsis 3. It doesn't mean that we have three different types of sepsis. The term sepsis 3 means it's the third updated version of the sepsis. Sepsis 3 still doesn't define sepsis completely because the set of criteria for diagnostic sepsis and the related conditions are somewhat arbitrary, and unfortunately we don't have a gold standard against which the diagnostic criteria can be calibrated. The criteria set by the Surviving Sepsis Campaign Guidelines are different from the criteria which are set by the Center for Medicare and Medicaid, CMS. I shall be covering all of this in detail, in the coming slide. In 2001, actually, there was a trial by Dr. Rivers called Early Goal-Directed Therapy, published in New England Journal of Medicine. This trial actually showed that there's a significant reduction in mortality in patients who were randomized for the early goal-directed therapy approach. Uh, I shall cover this study and some other study which followed this after about 10 years after the Dr. Rivers trial. In 2002, actually, surviving sepsis guidelines were introduced. This study was done in 2001. 2002, surviving sepsis campaign guidelines were introduced. Then in 2004, surviving sepsis campaign guideline released its initial guideline for sepsis management. Since that time, three additional updates have been done, and the latest, the most recent being in 2021. In 2016, the term, as I said, severe sepsis was dropped because if the mortality rate due to sepsis is so high, if it's higher than 10%, it means it's already severe enough, So why do we need to emphasize the word severe, So the term severe sepsis was dropped or removed in 2016. In 2017 update, qSOFA was not accepted or recommended as a best practice statement. When I say best practice statement, generally, I have a slide coming up, which generally means recommendation, So, like a strong recommendation. So, as I said, qSOFA was actually not recommended as a best practice statement. Therefore, SIRS, along with all other septic specific clinical parameters of the end organ dysfunction, were eliminated from the recommendation. Then we also have sepsis 1 CMS core measures, which is important to know for billing purpose. Otherwise, CMS basically may hold your payment. Let's start with the SIRS, which stands for Systemic Inflammatory Response Syndrome. SIRS was actually the main diagnostic criteria used until used in sepsis 3 definition. It was adopted since sepsis is a complex phenomenon with so many different signs symptoms, as I discussed briefly earlier already. The approach is to reach a global consensus with different criteria. So having so many different, how can we investigate this complex entity early enough, in order to intervene or to reduce the morbidity and the mortality associated uh, with this. As I mentioned earlier, some of the evolving definition of sepsis until the third and the last consensus sepsis 3 was agreed upon. Sepsis 3 definition was accepted and then, and it was decided to withdraw the SIRS criteria. SIRS term was not used anymore. SIRS criteria is if you look at SIRS, is not limited to sepsis only, because systemic inflammatory response can occur due to other inflammatory things too, for example, cytokine release syndrome or the tumor lysis syndrome. So uh, being so excuse me so complex, basically when I say inflammatory, anything which can break the cell open, release the content, can trigger the inflammatory response. uh, Now, sepsis 3 definition, I'll be like when I mention about sepsis 3, I'll be that's what actually I will be referring to for rest of my slide presentation. Sepsis 3 definition is basically defined as life-threatening organ dysfunction caused by this excuse me dysregulated host response to infection. Clinically, this is detected by, if you suspect a patient has infection in or they say documented infection, and they say acute increase in the SOFA score of 2 or more points. That's what sepsis 3 definition is about. Whereas septic shock is if it, sepsis plus persistent hypotension, which require use of vasopressor to maintain the excuse me mean arterial pressure greater than 65 millimeter of mercury. And if they say if the lactic acid lactate level is more than 2 millimole per liter, in spite of giving like a flu resuscitation, the lactate is still high, MAP is like you need to use vasopressor to maintain the MAP. That means patient has entered the septic shock. uh, if you look at it, septic shock is basically, I'll say, is a subset of sepsis in which the circulatory and the cellular or the excuse me metabolic abnormalities are so severe that the mortality rate increases significantly. So therefore, it's very, very important to recognize and treat the sepsis early enough or as an emergency. We have certain guidelines and bundles. If you if you follow those guidelines and those bundles completely, then we can reduce the mortality rate to some extent. Now, while you're screening the patient, excuse me, the first step is to find out if the patient has any infection, or you think that you're suspecting an infection, or does the patient have any wound, any catheter on him. Now take the appropriate steps to deal with those issues first. If there is a wound, take care of the wound, catheter, remove the catheter, calculate the qSOFA score, because qSOFA score if the increase means it basically is telling you the about the mortality. It's predicting the higher mortality. Basically, it's not a diagnostic tool, but it's going to give you some idea. If the qSOFA score is higher, that means more chances of death. So Now, if you look at the SOFA score, the baseline SOFA score, you can assume to be zero in patient with the no known or have no pre-existing organ dysfunction. SOFA score of 2 or more is considered to be sepsis. In general hospital population, a SOFA score of equal to 2 or more reflects a overall mortality rate of about 10%. Now, this is the table basically about the SOFA score. Uh, and SOFA actually stands for Sequential Organ Failure Assessment. This was actually developed to measure the organ dysfunction in ICU patients, just like the Apache score. And in fact, SOFA was not intended as a sepsis screening tool or to guide for the flu resuscitation. It's a complex scoring system. Look at how many organ system you have to evaluate because, excuse me, when you look at the patient respiratory, coagulation, respiratory or coagulation, liver, cardiovascular, CNS, renal system, all these 6 systems you have to evaluate, So looking at the SOFA, it's giving you idea, are they working okay, properly or not. In this chart, I have shown the, excuse me, modified version of this chart. A lot of labs and other parameters say, boy, you need to monitor, and it's time consuming to go through, evaluate all this system in detail. So what they did, they came out with the shorter and quicker version of SOFA called qSOFA. Now, qSOFA was instead of evaluating all 6 systems in detail, you basically evaluate 3 systems. Or patient respiratory rate, look at respiratory rate, look at excuse me, systolic blood pressure, and the patient's mental status instead of evaluating all the system. Now, look, just by looking at the 3 systems, GCS, respiratory, and the systolic blood pressure. Now, if the GCS score is less than 15, respiratory score is, excuse me, because I just recovered from COVID. I'm sorry, I'm coughing. This score is respiratory score is more than the 22 breaths per minute, and systolic blood pressure is less than. It should be it should be less than 90. Actually, I think it's a typing mistake. 100. As long as any 2 of these 3 qSOFA criteria are met, then those patients may be at risk of having sepsis. In those patients in whom you suspect infection, or if the patient has some wound, you need to evaluate them more thoroughly, monitor them more closely, and based on the clinical judgment, you might have to implement safe sepsis management early in those patients. Remember, qSOFA is not a diagnostic tool. It's just to prepare you early enough, like if you need to take like aggressive step early enough or no. Excuse me. Just like qSOFA, there's another tool called NEWS, which stands for National Early Warning System. It can be used to assess the risk of death from sepsis. NEWS is derived from 6 physiological parameters, and it can be calculated at the triage without the need for the blood test results. That's the difference between NEWS and the qSOFA. Now, higher the NEWS score, higher the risk of mortality. It is, excuse me. It is an aggregate score representing the risk of death from sepsis. Just like qSOFA, NEWS is also a reminder to urgently treat the patient with sepsis or septic shock. There are some risk factors as well which might predispose the patient for sepsis. For example, male gender, black race, age greater than or equal to 65. Excuse me. Bacteremia, if the patient is immunocompromised, diabetes, obesity, malignancy, community-acquired pneumonia, or if there is gram-positive bacteria. All these factors puts the patient at higher risk of sepsis. Let's briefly look at the general approach in patient with suspected sepsis or septic shock. There's no single test for diagnosis of sepsis. The patient can be presenting with various symptoms. You need to consider multiple factors. Don't just rely upon scoring system. Look for any signs and symptom of infection. Look for evidence of multiple organ dysfunction. If you have calculated to the SOFA or the new score, that can help you predict the mortality. But 2021 guidelines recommend against using qSOFA as a single screening agent. Now, start the resuscitation, monitor the hemodynamics, and see if the patient needs vasopressor. Excuse me. Monitor patient's lactate level. You need to be aware of now this slide. Excuse me. It's about the CMS sepsis definition, which you need to be aware of as well, because if you don't apply, use the CMS guideline, then they may hold your payment basically. Now CMS is not using qSOFA or other things. CMS is, excuse me, using SIRS criteria, which we already mentioned briefly early in the earlier slide. Now, especially they use such criteria, especially for patients who have a lactate level more than 4 millimole per liter. Now, CMS defines severe sepsis as a excuse me, infection or suspected infection with 2 or more SIRS criteria plus one sign of organ dysfunction, and it could be any one organ dysfunction out of these so many possible dysfunction. For example, it could be lactate more than 2, systolic blood pressure less than 90, mean arterial pressure less than excuse me 70, or if there is a decrease in systolic blood pressure more than 40 millimeter from the baseline. If the urine output is less than 0.5 ml per kg per hour for more than 2 hours, bilirubin more than 2 milligram per deciliter, or the excuse me, platelet count is less than 100,000 per microliter, INR is greater than 1.5, or PTT is greater than 60. Second, patient has altered mental status. CMS is excuse me. The CMS definition septic shock is severe sepsis plus initial lactate level greater than or equal to 4 millimeter per liter, even after giving 30 milliliter per kg of the crystalline bolus. Well, the difference here, septic shock versus severe sepsis, is in septic shock, you even if you haven't given the initial fluid resuscitation, blood pressure is still low, that means the patient has entered the septic shock, or the patient systolic blood pressure dropped more than 40 millimeter from the previously baseline blood pressure. These are basically I'll say CMS definition. Now, surviving sepsis campaign guidelines excuse me, have their own definition. Now, according to 2012 surviving sepsis campaign guideline, sepsis was defined as infection with many serious criteria. For example, some of the criteria listed on this slide are, most of these are basically SIRS criteria, and some are like organ dysfunction. It's like I'll say it's a busy slide. I'm showing here some general and some hemodynamic inflammatory organ dysfunction and some tissue perfusion variables. Mainly mainly going to cover the SIRS criteria here. Uh, Basically, the temperature, heart rate, and the respiratory rate. Okay. When we say the search criteria is met, basically is combination of, as I said, some general excuse me, general and inflammatory variables like temperature, heart rate, respiratory rate, or the WBC count. When we say patient has SIRS, that means like a patient is having any two out of these four condition. Let's say the patient's temperature is higher than 39 degree Celsius, the respiratory rate is 22, but the patient heart rate and WBC count is normal. That means the patient is having two criteria greater than normal. So then we'll say patient is meeting the SIRS criteria. When you look at the temperature, the body temperature, basically body resets its temperature either higher or lower. Most of the time, is set at the high temperature because like rise in temperature is kind of a, I'll say, protective mechanism to some extent for our body. What the body is trying to kill the bacteria by raising the temperature, but this comes at a cost, because when the when the temperature goes up, the blood vessels dilate. With the blood vessel dilate, we end up losing more heat. So heat is energy. So technically we don't want to. We want to conserve energy, especially when we are sick. So sometimes, like when too high the temperature, instead of, on one hand you're trying to kill the bacteria, but on the other hand you're also trying to dissipate more heat. Uh, but not every patient develops fever. In some patients the temperature actually can go down. They become hypothermic. Uh, Generally, this is seen in patients who have some immune like who have some immune system issue or immune compromise. And if the temperature is low, that's a sign of the increased risk of death in those patients. Now, just to just to give an excuse me, just to give you an idea about how fast these bacteria multiply, in fact, you'll be surprised that just in 2 days, just in 2 days, the way these bacteria multiply, just in 2 days, the bacterial population can outnumber the entire human population. Yes, it's true, because some bacteria can divide every 20 minutes. Now think of the now think for a moment, when thousands of millions of bacteria are dividing simultaneously every 20 minutes, they can easily achieve this goal, and the entire human they can exceed the population of the excuse me, entire human population. But unfortunately, or fortunately, they live under uh, very harsh condition. If, for example, if it's a small droplet of rainwater, like can drown or destroy millions of them. A few degree rise in temperature can destroy bacteria and virus. In fact, if you look at, some scientists have uh, used raising the body temperature to to cure syphilis. They introduced the malaria to have the patient high temperature. High temperature. I mean, patient do this kind of, especially in those patients who had syphilis, high temperature somehow kills the syphilis bacteria. Now, let me come back to the other variables beside the temperature, heart rate, respiratory rate. Other variable is the WBC count, which can be greater than 11,000, or it can be less than 4,000. Since uh, So this is another one of the inflammatory variable for SIRS criteria. Now, this was actually, I briefly talked about it, a study by Dr. Rivers published in New England Journal of Medicine in 2001. And this was basically a landmark trial which was done on 263 patients who came to the emergency room, and they all met the SIRS criteria for the severe sepsis and the septic shock. In this study, they looked at the 28-day and the 60-day excuse me, in hospital mortality. That was the primary endpoint goal of the study. Patients were randomized to receive either standard therapy for 6 hours or early goal directed therapy. To monitor the achievement of the hemodynamic goal, both arterial as well as central venous catheters were placed. Continuous central venous oxygen monitoring was done in the early goal directed therapy patient. Look at the standard early and CVP greater than. I'm sorry, I had to run away for it. I apologize for that. Well, the where I was. So mean arterial pressure goal more than 65, urine output more than 0.5 ml per kg per hour. Basically, the parameters are same in standard therapy as well as early goal directed therapy, whereas they had to do invasive monitoring in the early goal directed therapy, and the idea was to have the uh, monitor it early enough so that we can intervene and bring those if they fix those if they uh, somehow make the urine output more than zero point 0.5, keep the MAB more than 65, and saturation venous venous saturation more than 70%. This was actually excuse me, based on the static parameters. So once the patient gets sepsis, they introduce the central line. So the first thing was to give the fluid. The fluids, the fluids to achieve the to maintain CVP between 8 to 12, and then if the CVP was not achieved with the fluid, then the patient would receive vasopressor, and they will check the central venous oxygen saturation. If it was less than 70%, patient would receive blood transfusion or drugs like dobutamine to, to increase the cardiac output. This was basically spelled out very specifically what Dr. Rivers' protocol uh, was in the early goal directed therapy. Patients who were randomized for the early goal directed therapy showed significant reduction in mortality. Mortality about like 30% versus 46% in the standard care group. Mm, uh, 28-day mortality, 60-day mortality were also significantly reduced in patients who received the early goal-directed therapy. Now, early goal-directed therapy also had improved physiological parameter like the mix, excuse me, oxygen saturation, lactate, base deficit, and the pH. Now, actually, early goal directed therapy patient received more fluid transfusion than vasopressor, and there was no difference in the mean duration of the vasopressor therapy, duration of mechanical ventilation, and the hospital length of stay. The results of this study actually uh, changed the way sepsis was managed. What happened here? Sorry. So, since data from this study showed excellent uh, outcome, there was a greater than 10% absolute risk reduction, indicating that excuse me, early goal directed therapy decreases mortality. Therefore, excuse me, many clinicians started following early goal directed therapy, but since it was a single center prospective randomized controlled trial done on excuse me, small number of patients, about 10 years later, the early goal directed therapy protocol actually started getting challenged. So, excuse me, I guess I had to. I'll stop here because I apologize for the severe cough. I'll continue in the following slide. Thank you very much for watching. Thank you.